Welcome, everybody, to our workshop here entitled Social Complexity in CF, Understanding How External Influences Impact Outcomes. My name is John Powell. I'm a pediatric pulmonologist from Lurie Children's in Chicago. My co-moderator here is Chandra Gordon. She's a licensed master social worker at the University of Kansas Health System. We're thrilled to be your moderators here today for this very important topic. So health disparities and inequities have been sewn into the fabric of the medical system and affect health outcomes of minority and marginalized communities across numerous disease processes. Cystic fibrosis is just one of many. And so there are a range of variables that contribute to health disparity and inequities in cystic fibrosis. This session focuses on the intricate interplay between complex social systems, social constructs, and external influences and how they affect CF outcomes on a global, national, and local level. The speakers today will touch upon many important topics pertaining to health inequities and disparities within CF. This topic is inherently personal, emotional, and sensitive to many individuals. So with that in mind, I kind of want to create a safe space that's inclusive to all ideas and opinions, so that we can have a free and open exchange without a fear of people speaking up and having an actual fruitful discussion. So we encourage the participants here in this room and joining us virtually in conversation and asking tough questions and giving perspective on how we can tackle this complicated issue. My hope is that we are moving forward from a time where we're just kind of documenting that health disparities exist and moving to the next phase of basically actionable items and how we can make changes moving forward. And so, as you guys are all aware, throughout the many different workshops and sessions you've been, all of our questions for right now are going to be going through our devices and apps. So please, throughout the session with each speaker, just make sure that you're putting questions in, putting in discussions, and Chandra and I will go ahead and filter them and kind of ask that of our speaker. The format will be 15-minute presentations followed by 5 to 8 minutes of questions. Sometimes technology breaks down, so just scream loudly and we'll repeat. I think everyone's encountered that as well. And so with that, I think I want to kind of move forward so that we can get started. As moderators, we have no relationships to disclose. And the last point I want to make, and hopefully you've seen this message on many other places, but I do want to encourage for the safety of our presenters and attendees to urge the CF Foundation to commit to ensuring that future meetings are held in locations where elected leaders understand the importance of reproductive freedom, gender-affirming care, and the sanctity of physician-patient relationships. And so, with all that in mind, I'd like to bring up our first speaker, Jessica Hudson, who is coming from community engagement, and she's the lead there at the CF Foundation, or here, I guess, the CF Foundation, because it's the CF Foundation event. Her talk is entitled Examining Representation, Education, and Resources as Barriers to Engagement in Cystic Fibrosis Communities of Color. So.
Thank you. Thank you, everyone, for being here, and thank you to the chairs for having me. I'm excited to present some of this information, and just want to note, I'm Jessica Hudson, obviously, as they just said, but I'm also presenting this information on behalf of my partner and co-author, Christina Roman. She's in the audience. My presentation is Examining Representation, Education, and Resources as Barriers to Engagement in CF Communities of Color. And I do not have any relationships to disclose for this presentation. So here's a quick overview of what I'm hoping to cover in our talk today, including briefly discussing current data and disparities we know to exist in CF, an overview of previous listening efforts in communities of color, and what we'll spend most of our time today are focus groups that we conducted as a follow-up to that survey, and kind of go through some of the key themes and takeaways from the focus groups, and then I'll wrap up with some next steps and ongoing work. So to start, I wanted to ground our discussion in what we know about the disparities that exist for people of color with CF. We know that infants of color are less likely to be detected on prenatal and newborn screens and are 2.5 times more likely to have failure to thrive. When we look at clinical research, we know that Hispanic and Black people with CF are underrepresented in our clinical trials. We also know that 25 to 30% of Black and Hispanic individuals are currently not eligible for modulators. And last, we know that Black and Hispanic people with CF have a twofold higher risk of death before the age of 18. Achieving health equity is the major overarching goal of this work. So to kind of ground us again in this discussion, I wanted to share this definition, and I'll quickly read it. Health equity means that everyone has a fair and just opportunity to be as healthy as possible. So this requires removing obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs and fair pay, quality education and housing, safe environments, and healthcare. And the picture on the slide that I love really shows the difference between equality and equity. So to get a baseline of the current perspectives of people of color in the CF community, back in November of 2020, we launched a survey to better understand the needs of people of color in the CF community and get a better understanding of what barriers exist to engagement. So in that survey, we included open-end questions that we'll discuss a little bit later, but we also included these 3 kind of agree-disagree statements that we thought would be good to share to kind of lead us into the next piece of this discussion. So looking at these questions, we first asked if individuals felt it was important to have a voice in the CF community, followed by if individuals currently felt included in CF research and in the CF community. So as you can see, around 75% of respondents strongly agreed it was important to have a voice in the CF community. However, only 26 and 24% currently felt included in CF research and in the CF community. So this is important because I think it shows these individuals feel that it's important to have a voice. They know it's important to engage. However, there are barriers that exist that are preventing engagement. So as a follow-up to that survey, again, we conducted focus groups with communities of color to dive deeper into some of the themes that we heard in that survey. So again, in that survey, we did have open-end questions around how to better address the barriers to engagement. And we came away after theming and coding with 3 major themes, which were education, representation, and resources. So whenever we go through the focus group questions, you'll see that they're broken up into those 3 categories. So these questions were, and of course, all the questions were developed around those themes for the focus groups. Invitations to the focus groups were sent through 3 major areas. So starting with the communities of color opt-in list, this is a group of around 80 individuals who have raised their hand, all that self-identify as people of color or parents of children of color with CF, and just kind of raise their hands to be involved in the work moving forward. We shared invites with Emory and KU care centers. We had a relationship with those care centers and wanted to get their patients of color involved. And then last, but certainly not least, we shared through Community Voice. And for those who are not familiar, Community Voice is a volunteer program for patients and families to get involved in receive engagement opportunities of their choice, to just get involved and inform some of the work at the foundation. For participation, we had about almost a 50-50 split between those that identified as Hispanic or Latinx and those identified as Black and African American. And when we look at CF Connection, majority were parents of kids with CF or adults with CF, and we also had a grandparent and spouse participate as well. Alrighty, so jumping into the focus group questions, again, where we'll spend most of our time, and I'll try to go through each question and share some of the key takeaways and then share some of the quotes from participants in their own words. So looking at representation, we first asked participants, what does representation mean to you? And there were 3 major themes here, starting with visual representation, and this was really a major theme throughout the focus groups, so you'll hear me talk about it a lot. But here, participants really flagged the importance or a lack of representation across really all of our platforms, website, social media, as well as lack of representation in staff, and that includes care centers and chapters. Equity and inclusion were also mentioned by a majority of participants here. So this included feelings of tokenism versus actual inclusion, as well as a need for support groups and safe spaces for people of color. Participants also mentioned a need to improve visibility for current safe spaces and support groups that already exist, many of which that are led by people of color in the CF community. And last, newborn screening. Again, this was a major theme really throughout the focus groups, but unfortunately, almost all of the participants in the focus groups had some experience with either delayed diagnosis or misdiagnosis. So after participants kind of shared those experiences, they also shared kind of the connection that they saw between stereotypes and some of the disparities that we know to exist. So as a follow-up to that question, we also asked, still under representation, if individuals felt representation in data was important. Data mistrust was a major theme here. There were many comments around some mistrust in things like our registry data, with kind of questions around, if it was so hard for me to get a diagnosis or if it's so hard for my child, how can I trust the numbers that I'm seeing? Data transparency, another theme, including how we share back our data with the community and the need to expand our reach and making sure that we're not just sharing information with our highly engaged individuals. And again, representation, and in this instance, representation in our surveys, data, clinical trials, of course, and even some mentioning our national committees and work groups. So the last question under representation, we asked, how does representation play a part in your decision to engage? Again, visual representation, another major theme here. Not seeing Black and brown people represented across our staff and platforms, again, plays a major part in individuals' decision to engage with us. Past negative experiences were big here, which was, I would say, was hard for us as staff, hearing, that individuals have previously participated and engaged with us did not have a great experience. So experiencing things like poor culture on some of our committees, tokenism, again, feeling like they were expected to speak for everyone from their community as just one person, feeling like it was their sole responsibility to kind of flag disparities and health equity. And then last, hesitancy. I thought it was good to mention there was an overall feeling really throughout the focus group, I would say, around, why now? If you haven't wanted to hear from us before, how do we trust that you're wanting to hear from us now? And just to share some of the quotes and direct quotes from some of the participants, and I'll let everyone kind of read on their own, but I did want to try to read maybe two just for the sake of time. And I'll start with the top, which says, I just saw the numbers and I just don't believe them. It's assumed to be a white disease. So if it's assumed to be a white disease and they are not looking for it, you are either lucky to be 54 and diagnosed or you're dead and nobody ever knows you had it. Next quote says, it feels like they want me as a face and for my skin color to appear inclusive. And then the last is, I'm new to this and I've never been involved. I didn't want to because I knew there was no one that looked like me. So moving on to resources, we then asked participants, what are the needed resources specific to people of color in the CF community, of course, from their perspective. Screening and post-diagnosis resources was huge in this space. So again, because so many of the parents in the focus group had experienced just kind of a tough journey to obtaining that diagnosis, they talked about needing more resources around the signs and symptoms of CF to kind of help them advocate for their child in those spaces. And again, kind of feelings of isolation after they received a diagnosis and kind of not knowing where to go from there. Educational materials in areas such as nutrition and just kind of more practical tips and tricks on kind of everyday life with CF. And then access to resources. So many found it difficult to obtain information around what are our ongoing research, priorities, clinical trials, treatments, things of that nature. I think it's important to also mention here when we talk about resources, many were surprised to learn about how many resources were available and how many engagement opportunities were available to the point where individuals felt like maybe things had been withheld from them in the past. So as a follow-up to the previous question, we asked individuals about the best way to receive information and opportunities to engage. Care teams were, of course, like the number one answer. Everyone mentioned that care teams were a trusted source, and it's also a convenient way to receive opportunities. You're already in clinic, you're already in your visit, you kind of want to make the most of that visit and really hear about every opportunity that there is to engage. That was closely followed by affinity groups, social media, again, some of those support groups, safe spaces that already exist, many of which are led by people of color in the CF community. So utilizing those spaces to provide that information around opportunities that are available. And participants also flagged rural populations. So keeping rural populations in mind, not only when we're figuring out how to share our information, but also when we're engaging. So thinking about things like, everyone doesn't have access to tech-based communication, so reaching back to things like phone calls or even mail. And I will pause here again, and I will read probably two of these for the sake of time. So these are quotes again from participants in the resource section. So the first one says, "When my son was diagnosed, you just find out your son has a life-shortening disease, and you're given a book and a bag with papers in it, but it's kind of like you're left on your own, good luck." And at the bottom it says, "Some parents just know what they need for their child to survive, but they do not specifically understand the science behind it. What is going on in a child's body in a language they can understand? Not everyone understands certain scientific terminology or certain words." So moving on to the last section, which is education, we only asked one question in this section, which is what training is needed for CFF staff or care center staff? And this was very straightforward, right? The answers that we heard, cultural sensitivity training and cultural awareness training were like the number one answer that we heard from everyone. And this was after many of the participants shared negative experiences around, being in clinic and being repeatedly asked if are they sure they have CF, going to events and being accused of like stealing parking because they weren't sure that they were there for the event. And even an individual that shared as recent as 2020, going to an event and receiving paper in her hand that said CF is a Caucasian disease, and when she inquired about it, she did not receive the response that she thought was warranted. So just to share a few of the last quotes from that education section, the first one says, "My child did newborn screening. What they found, they blamed on my breastfeeding. If the nurse or doctor is telling me don't worry about it, I'm not going to worry about it. A month later, your child is dehydrated, showing all the symptoms. I don't know how to rewire that." The next one says, "I had an experience where I was in clinic and one of the doctors came in with his medical students and said, 'Oh, you have CF, you're not white.' I don't want that to happen to anybody else." And the last one is very long, but I don't want to cut what she said short because it's important. But she's saying, "When I go to events, I would see materials that explicitly say this is a Caucasian disease. And when I spoke up about this, about the resources that didn't include Hispanics, didn't include Black women, the underlying messaging was it's not that important. And when I spoke up, this was in 2020, this was a year ago, nobody else in the room said anything. When I mentioned we should be included, nobody said a single word. That just made me so angry and sad for kids being diagnosed today." So I know that was a lot to try and digest, but I did want to share that as we're hearing from, these individuals, not just in the focus groups, but other listening efforts in this space, we are using what we're hearing to inform ongoing work and next steps. So I just want to share a little bit about what we're doing and what's coming up. So in the inclusion space, we are working to develop tools to improve experiences on our committees and work groups, including a selection best practices tool, which helps kind of make sure that our selection practices are equitable, as well as developing a training on health equity to make sure that there is a foundational understanding of health equity from everyone in the committee, including committee leads, and it's not the sole responsibility of any one person. In the health equity space, there is work happening in the newborn screening space with a new committee that includes patient advocates. There is an RFA on health equity being developed as well to encourage research in that space. When we look at clinical trials, we've actually done similar listening efforts with research coordinators to better understand from their perspective some of the barriers that may exist to including diverse populations into research trials. So understanding from their perspectives what those barriers are and seeing what we can address, things like reimbursement policies, travel, things like that, and of course, continuing to advance mutation agnostic therapies. Alrighty, so in closing, I just want to acknowledge a few individuals. Again, Christina Roman, who's my partner in all this work. Jen Green, who also partnered with us on this and continues to partner in the work. JP Clancy and Sue Sullivan, who are sponsors of the work and thank them for their leadership in the space. The CF Foundation External Racial Justice Working Group, who I'm a part of, and this work goes hand in hand with. And of course, the CF community members. We really, really honor their bravery. They had many reasons not to trust us and to not come into that space as open as they did. And so we don't take that lightly. And we really thank them for that. And I will open it up for questions.
Thank you, Jessica, for that presentation. It's very, very enlightening to be able to have that lived experience and perspective. So one question we have so far is, what surprised you most when conducting the focus groups?
That's a very good question. I think it's honestly the openness of the community members and the willingness to share some of these stories, which if it was painful to hear, I can only imagine how painful it is to continue to say it and share it. And they were open and they were trusting of us. Again, historically, they did not have a reason to trust us, but they did. So I think that really surprised me more, and just their willingness to continue to work with us in the space as well.
So there looks like and feel free, more questions, guys, come in. And so there's a question from the audience asking, what was the Latinx community comments discussion and the lack of Spanish-speaking providers and/or lack of access to Spanish-speaking support groups and educational resources, if there was any?
Yeah, I think it was all incorporated together. So there were similar comments around some of those things. So again, the need for translation, there were, if you read the full focus group report, there were probably some more specific comments around the Latinx experience specifically, but similar to what we had here, a lot of comments around just the need for representation, of course, in our staff, care teams, all those things, but similar experiences.
What immediate steps can care teams take with this information?
I think the best step and the most immediate is to try and share opportunities with community members. And the best way to do that, Community Voice is an amazing program where patients and families can share their perspectives, and not just on the back end, but on the front end. And they can see their work and their perspectives being included and informing our work moving forward. So I think sharing programs like Community Voice, where patients are able to, again, share their perspectives, share their stories, and see it in action, is a great immediate next step. There's a question out there.
Oh, Dr. Giles?
Yeah, that's a good question. I do want to say that all of our listening efforts to date have been open to all people of color. So anyone that identifies as a person of color is able to participate in all of our listening efforts to date. And the foundation, the work is expanding. The work started kind of with Black people, African American, and Hispanic populations, and that work is expanding to other groups as well. But to date, everyone has been included, as long as they self-identify as a person of color, has been included in our listening efforts.
Another question coming in, is there a possibility of parent mentoring from the focus groups? My clinic is in Detroit, not me, with this person's. Clinic is in Detroit, very diverse, and we struggle to find mentors and pairing. Would love to refer to like more focus groups.
That's a very good question. Yes, it's a great idea. I think reaching out to us, or to me personally, we could probably kind of talk more about that. There are a lot of peer connection programs under community partnerships, so that's a really good idea. So please, whoever, send that to me.
Sorry. Is there a Canadian chapter or equivalent of that for Community Voice?
There is, yes. Christina Roman. They just launched, okay, it's called Elevate, is the Canadian equivalent to Community Voice. Thank you.
And then another question is, will the Health Equity RFA require community members in the team science approach? Is that something you can speak on?
I'm not sure. I'm not in charge. Yes. Thank
Okay.
you. Great. There's hope. The
Okay.
people who
The
are in
answer is
charge of
yes.
that are here.
Okay. Awesome. Okay. Do we have to do these next steps? I have a question. I mean, there are more questions, sorry, but I have another one.
Okay.
I have the microphone. So, when it comes to like representation, and everyone understands the importance of that, and especially with like minoritized and marginalized groups, like how do we get through the hurdle of mistrust? Like as a provider, as like care team members, because historically there is good reason for mistrust. And so is there anything that you glean from the focus group or with your experience?
Yeah, I think an important piece that sometimes people miss is like transparency, right? And being transparent, not just about what you're trying to do moving forward, but transparent about what went wrong in the past. I think that hearing that validation about, I'm not crazy. I know that these things have happened to me. There's a reason that I don't have trust. Hearing that validation from your care team or the people that are kind of trying to lead this work really empowers community members. And we've heard that, we've heard, thank you for saying this. Thank you for sharing this information. It helps me kind of trust the work that's moving forward.
Since the focus groups, it's moving. All right, since the focus group, has anyone that participated, do you know if they've gotten involved in their Centers Family Advisory Committees?
In their advisory committee, I'm not sure, but many of the folks group participants have been involved in our work. The external racial justice work, they work with us in Community Voice. Many of them have gotten involved and have become like key players in some of our next steps.
All right, that's all the time we have for the questions at this time.
Thank you.
Yeah. Perfect. All right, so we want to introduce our next speaker, which is Jonathan Guo. I'm sorry, I do mispronounce that. He is a medical student at Imperial College of London, and he will give a presentation on the talk of current prices versus minimum cost of production for CFTR modulators.
Great. So, hello, everyone. My name's Jonathan. Thank you very much for having me. I'd just like to say, first of all, it's a pleasure to be here, though it's obviously always risky leaving the UK nowadays because you never know who's going to be Prime Minister when you get back. But yeah, nonetheless. So this is just to say that I have no disclosures regarding this presentation, just before we get going. So, as I'm sure everyone is aware, the advent of highly effective modulator therapy has really revolutionized the treatment of CF, and it represents an unparalleled opportunity to improve quality and length of life for almost all CF patients. However, the list prices for CFTR modulators have been set between $270,000 and $310,000 per year. Their cost means that even after regulatory approval, the medications remain functionally unavailable to patients unless reimbursed by governments or health systems. Even still, the high prices of CFTR modulators pose resource allocation dilemmas to even the most robust of health systems, with patients left waiting years to receive treatment pending pricing negotiations. So how does this affect treatment access in the real world? In 2020, our team set out to try and answer this question by estimating how many people had CF worldwide and what proportion were being treated with Trikafta. Put very simply, our results indicated that at the end of 2020, Of the 162,000 people estimated to have CF worldwide, 65% were diagnosed and just 12% were receiving triple combination therapy. Translating these findings to the real world, if you were to take 8 children with CF, 5 would receive a formal diagnosis, 7 would not have access to Trikafta, and just 1 would be receiving treatment with the best available therapy. Therefore, as one can see, this pricing strategy really represents a huge barrier to effective and equitable treatment. Now, it is important to say that since our study, the landscape of reimbursement and treatment availability has improved. Though Vertex, the manufacturer, has not officially published this data in a transparent manner, by our count, Trikafta is now reimbursed in around 30 countries globally, up from just 6 at the end of 2020. However, you may notice that every single one of these countries lies distinctly within the global north. And not just that, but they are almost exclusively the richest countries in the world. When you compare this with the data we found on the known or diagnosed global CF population, it's quite easy to see a stark difference, primarily in that current country-level reimbursement of Trikafta falls far short of the global disease burden. Furthermore, there are entire continents without access to any CFTR modulators, with thousands of patients in South America, Asia, Africa, and even Eastern Europe neglected from the benefits that are currently enjoyed by patients in North America, Western Europe, and Australia. And so whilst the current pricing model frustrates treatment access in high-income countries, it entirely disregards patients and health systems in lower and middle-income countries, where poorer CF outcomes are already experienced, thereby creating a two-tiered standard of care. Modeling has indicated universal introduction of Trikafta in 2021 would reduce the number of people living with severe lung disease by 60% and deaths by 15% by 2030, with these benefits halved if introduction was delayed to 2025. I think this really demonstrates that any delays to access result in further disease progression and years of potential life lost for patients. And so what can be done to address this problem? The good news is that similar challenges in treatment access have been overcome successfully in other disease areas. For example, in the case of antiretroviral therapy used to treat HIV, similarly prohibitive drug prices were reduced by over 90% via generic competition introduced through voluntary licensing. These price decreases were deemed ambitious and infeasible at the time, and yet have resulted in some of the greatest successes in modern public health. Therefore, following this precedent, our study aimed to provide estimates of the minimum cost of production for CFTR modulators and to compare them with current list prices to evaluate the feasibility of increased global access to treatment. Now, it should be noted that whilst we included in this analysis all 3 combination modulators, we will mainly be focusing on Trikafta in this presentation. So as previously outlined, our methodology consisted of 2 main components. To estimate the minimum cost of production, we adapted an algorithm validated in previous research to reliably estimate production costs for standard oral formulations. This algorithm is based upon pricing data of shipments of raw active pharmaceutical ingredient, or API, intended for mass production. This was extracted from the import-export databases Panjiva and Sino-IMEX from 2016 to 2021. And this is just a sample of some of the more recent data from 2021, taken from one of these databases to illustrate what some of this shipment data will have looked like. It should be noted that no API data was available for Elexacafta, likely due to its novelty. Consequently, for this API, estimates of per kilogram costs were made via published routes of chemical synthesis extracted from patent information. Similar analyses were also performed for all other APIs to validate our estimated costs of production. We also conducted a survey of national pricing databases in August 2021 to generate a snapshot of publicly available data on list prices for a 1-year course of treatment for each modulator. And so taking a closer look at our production cost estimates, we started by calculating the weighted mean price per kilogram for each API. This was then combined with dosage data extracted from the British National Formulary to calculate the API cost for a 1-year course of treatment, including an assumed 5% loss during production. Total production cost per tablet was then calculated by incorporating the cost of excipients. So these are substances required for formulation, such as stabilizers, binding agents, and coatings, and formulation into a tablet for oral consumption. Previous research has estimated average pharmaceutical excipient costs to be around $2.63 per kilogram of finished product, and formulation cost at around 1 cent per tablet. We then incorporated a profit margin of 10%, as well as an average tax of 27% to calculate the sale per tablet price. And lastly, we calculated the total number of tablets required for 1 year of treatment to generate the final estimated annual production cost. So there are several key assumptions underpinning our model. The first is that API will be sourced from either China or India. These are the countries that were included within our search strategy and are the world's leading producers of both generic medication and API. This is also why the calculations within our model are based upon generic production in a factory in India. This methodology is also specifically adapted to formulations of tablets for oral consumption and not other forms of administration. Next is robust mechanisms of competition, which tend to drive down prices. Of course, if you simply have one generic manufacturer within a region, you essentially just have another monopoly situation. And finally, that profit margins are limited to just 10%, as of course this represents a hugely variable, though largely anthropological component of the final price. As mentioned previously, our algorithm has been validated within the literature against medications in several other disease areas. This includes 148 medications on the World Health Organization's essential medicines list, direct-acting antivirals using hepatitis C, antiretrovirals for HIV, repurposed treatments for COVID-19, insulin biosimilars for diabetes, and tyrosine kinase inhibitors for cancer treatment. Taking a closer look at DAA specifically, our methodology was applied in a study published in 2014, shortly after their initial synthesis in 2011. So the launch price for a 12-week course of the combination treatment sofosbuvir declatesvir at the time of the study was $147,000. Our methodology estimated a minimum production cost of $166 at the time. And following adoption of voluntary licensing by the originator, in 2020, a course of sofosbuvir declatesvir could be purchased in India for just $40. So moving on to the actual results of our study, across every country surveyed, the prices of originator CFTR modulators were well over $200,000, as can be seen here. Comparatively, our estimated minimum cost of production was $5,700. This puts our estimate for Trikafta 98% lower than the US price. Looking at our results for all CFTR modulators, we can see that overall, the highest international prices were found in commercial US pharmacy and the lowest in Argentina. This is likely because in Argentina, generic versions of modulators are available. In all cases, commercial prices around the world were many times higher than the costs estimated by our model. So overall, what we can take from this is that reimbursed or not, modulator therapies currently represent an enormous financial cost to patients and health systems internationally. In spite of this, our results indicate that CFTR modulators could be produced for a fraction of current list prices. More specifically, the cost estimate for Trikafta, the current best available treatment, was 98% lower than the top list price. And overall, for each combination treatment, the highest international price was found in commercial US pharmacy, and the lowest in Argentina, likely driven by generic production. However, when interpreting these findings, there are of course some key limitations to keep in mind. Our model indeed does only factor in costs associated with drug production, and therefore does not account for other costs required to bring a typical drug to market, such as bioequivalence studies, regulatory approval, or investment in new production facilities. Additionally, it is likely that in many jurisdictions, the actual prices paid by health systems for modulator therapies is lower than the list price following negotiation. While such data is not publicly available, these discounts tend to range from around 20 to 30%, which still places the final prices far higher than any of our estimates. In previous analyses using similar methods, higher volumes of API shipments were generally identified. However, it should be noted that larger scale production of both API and finished product generally sees prices fall rather than rise. And finally, due to the assumptions built into our model, the estimates generated presume a fairly specific scenario. Consequently, it's very important to be clear that these figures do not represent precise predictions of future drug prices, but rather demonstrate the economic feasibility of lower prices and wider access. So in our results, one can see that the lowest market price for each modulator was found in Argentina. Looking further into why this is reveals quite an interesting situation. So currently in Argentina, patent restrictions do not apply, and so generic versions of CFTR modulators are available. Commercial export of these drugs is not permitted, and so the market for generics is mostly limited to domestic Argentinian CF patients. And there's an absence of the competition usually required to drive down drug prices. Yet even in these fairly restrictive conditions, these generics form the lowest list price for every single commercial modulator therapy. As such, this can almost be seen as a case study in price reduction. And so why are prices so high? Some justifications center around high production costs. Yet our results indicate that minimum costs for these medications are likely far lower than their retail prices. Other rationales include the costs of research and development. It is of course vital that these costs be recouped to fund further research and drive innovation. However, CFTR modulators represent some of the most valuable orphan drugs on the market, with total revenues since 2018 reaching $27 billion, far outstripping even the most generous estimates of the cost of bringing a drug to market. And finally, cost-effectiveness analyses by both government and independent bodies have concluded that the benefits of CFTR modulators do not warrant their prices. It therefore appears that these prices are not determined via production expense, R&D costs, or efficacy, but rather what the market will bear. With patent protection for Trikafta expected to last until 2037, it seems that the current monopoly on modulator treatment is not set to change. There is no transparent plan to increase access to CFTR modulators, aside from compassionate treatment programs run by the originator to provide the drugs at lower cost to individual patients for a limited time period. On a fundamental level, the status quo is not working. People are being left behind, and it is clear that the scale of the issue demands as a solution not philanthropy, but solidarity with patients to provide meaningful action at a country rather than individual level. And so what can be done? One strategy which you might have noticed has cropped up several times in our presentation is what is known as voluntary licensing. This involves the originator company permitting third parties to manufacture and sell specific products whilst they are under patent. Within this arrangement, the originator may maintain royalty payments for any profits enjoyed, and it's a policy with a proven track record in other disease areas and resource-limited settings, thereby providing both a precedent and framework for future action. Within the community recently, I think there's been quite a change in the perceptions of CF as a disease. I remember earlier in medical school myself, I was taught that CF was an Anglo-Saxon disease, only affecting people of European descent. And I think what we've seen recently is a move away from this and towards recognizing CF as a condition that can affect people of every ethnicity and in every part of the world. Whilst it's clear progress is being made in the conceptions and beliefs surrounding CF, this must be followed up with tangible outcomes. There is little sense in acknowledging the worldwide burden of the disease if we cannot provide meaningful, equitable, worldwide treatment. Furthermore, neglecting those outside of the global north from the transformative effects of modulator therapy serves only to create a perverse situation where instead of benefiting all patients, medical advancements instead end up widening existing disparities in care. And so to conclude, the prohibitively high price of highly effective modulator therapy perpetuates international disparities in CF care. These drugs are currently only available in the world's richest countries, and without urgent action, patients outside of these countries will continue to be neglected. Our results indicate that modulators could be produced for over 95% less than current list prices. These results, alongside the real-world example of Argentina, indicate voluntary licensing and generic production of CFTR modulators to be a feasible solution to improving country-level access. Today, more people than ever are living long, fulfilling lives with CF. This is thanks to the collective actions of a dedicated international network of clinicians, patients, and advocates. However, as per the mission statement of the CFF, what we must do now is ensure that these victories are available to all those with CF, regardless of the country in which they live. Thank you very much. I'll be happy to answer any questions.
That was a great talk. So one of the questions was also when I was going through your presentation was something I was also thinking about. But we often hear that high drug prices are in part due to the need to account for research and development and simply not manufacturing and simply not manufacturing. So can you comment on that?
Yeah, sure. I think it's definitely true and important to recognize that innovation needs to be rewarded and that money from revenues does go towards R&D. So I think Vertex in 2020 spent around 1.8 billion on R&D. That's around 32% of their revenue, so slightly higher than the average pharmaceutical industry company. That being said, though, these profits and the money that is being made, they're not all going towards R&D, although a big portion of it is. So I mentioned sort of the revenues that have come in since 2018 of 27 billion. It should be noted that alongside that, there's been net profits of 11 billion, and that includes costs of manufacturing, that includes costs of marketing and R&D investment. So I think, while it is true, it's important to note that there's a balance to be struck. So profit is not inherently unethical, but it can't come at the cost of patients, and it can't come at the cost of sort of quality of life years and things like that.
Yep, question from the audience?
We have a couple of replays is prepared to apply every 2 months to Argentina to buy our pocket education service. It's a real battle, and the rest of the world. Thank you for highlighting.
Thank you. It's very humbling.
And did everyone in the back hear that comment? Okay, I had a suspicion. And so he was thanking Jonathan. So he's a physician from South Africa who does not have access in their country to these modulators. So was thanking Jonathan for highlighting that need internationally, and that also that he has several patients that fly on a regular basis to Argentina and pay out of pocket just to get this life-saving drug. I saw another hand in the audience. Yes.
Another question from the audience as well.
I just want to have a birth answer of Turkey. I'm the father of a 14-year-old pediatrician. I also am the board of the pediatrician. I mean, this is a great thing. I mean, when you have a sick disease without a solution, at some point you can accept it as pain and go to pain. But when there is a solution and you can access it while other people are accessing, this is deep suffering and it is the anger. This is the most important presentation. I'm not a scientist, but this presentation is so important. So the, I don't know, just dedicate it.
Did the audience in the back hear what was shared? No? Okay, he's a father from Turkey and just wanted to share his appreciation for this presentation because it speaks life to the needs of individuals who don't have access and ask that we all continue to fight so that it is available to all. Another sentiment sharing, living close to countries that don't have access as well, and just again the need to continue to have this conversation.
Can you give us a sense of, I know you were talking about kind of proportion of the additional cost for additives to drugs and all. So there's marketing and there's education. And there are drugs that are on the commercials on TV that they're trying to sell to everyone with hypertension or obesity or whatever. And they need marketing. But we have CF centers, and all of the patients almost are in centers. And so I don't know what factor in, but they also pay for the education at this conference. And so I think we all have to be accountable to know that we are benefiting or taking advantage of, or I don't know. But anyway, there is a need that you have for some degree of education when you put something on the market, but there's also, in my view, a lot of excessiveness in education and marketing. So I don't know if there is any kind of factor you put in, because you kind of mentioned it once, but mostly talked about R&D.
Sure. So the question was essentially centered around, we've talked about the R&D costs that Vertex reinvest money into, but also they spend a lot on, for example, marketing, education, and for example, they sponsored this conference was one of the pertinent points. I think that's definitely a good thing to discuss. I myself I have to admit, I haven't looked into sort of the money spent around there, and I don't know how transparent they are about that either. But what I will say is that does form obviously another component, but again, that is incorporated within sort of the net income that they make, and that's already accounted for within that figure. And whilst it is important, I think it's also vital that Vertex sort of talks about and actually has a transparent plan for what they're going to do about this situation, because it is obviously, as we've heard from all the comments today, and even some of the other talks within the conference so far, very pertinent. We've seen other companies in other disease areas putting patients first, issuing these voluntary licenses. So for example, Gilead for direct-acting antivirals, GSK, Novartis. And I think the question that we need to ask now is really, is Vertex willing to do the same thing and put patients first in these areas? Because as you mentioned, they have a lot of power both within actually owning the patents, but also within the education and the sort of messaging that they put out. I think it's just important to get their position on this as well. Yeah.
And so we just came from a program directors meeting that also signaled that Vertex is going to increase their copay to patients, and that as program directors, we're advocating for our patients to stop that from happening. I know Vertex is here at this CF Foundation, at this NACFC, and so one of the questions I think that's asked here by the audience and also powerful is, has Vertex responded to this data?
So to my knowledge, no. I have to say I haven't received any emails or anything, but that's just me. I think so. Some of this work was done in collaboration with parents in the UK. So there was a big sort of kerfuffle in 2019 around Orkambi, because the NHS essentially had a bit of a difficulty getting to grips with the pricing, and there was, again, a prolonged negotiation. And so some of the parents from that, I think, having seen that fight, wanted to sort of raise awareness about this and deal with this. So they've been very much knocking at Vertex's door, asking about what their plan is, and I know some professionals within other countries have been doing the same thing. To my knowledge, I have to say, so far the response has been leaving a lot to be desired. But again, I'm not the one leading that, but that is just my understanding of the situation. I have to be honest about that.
All right, there's a question in the back.
Thanks very much.
So I truly want to thank everyone for their testimonials. And I want to thank Jonathan for, I know we went a little over, but I think this is a really impactful and important presentation. That's one of the reasons why we picked it. And I know that you're just one person, but you're in a room filled with people that have that same anger, that same want, that same need to push for ethical pricing of drugs and giving access to patients all around the world to these life-saving medications. So thank you, and thank you.
Thanks very much.
Okay, sorry, I went a little over there. So our next speaker is going to be Zain Mohammed Chima. He is also a medical student coming from McMaster University in Ontario, Canada, and he will be speaking on measuring burden of disease for Canadians, both adult and pediatric, with cystic fibrosis and their caregivers, a systematic literature review.
Okay. Good afternoon, everyone. My name is Zain, and on behalf of my study team, I would like to thank the organizers of this event for inviting us to present our preliminary work on the burden of cystic fibrosis. Today, I'll be specifically sharing with you a summary of the cystic fibrosis costing literature in Canada and from around the world. With regard to disclosures, this work is supported by Cystic Fibrosis Canada, and several members of the study team are also employed by CF Canada. So what is burden of disease? Well, burden of disease refers to the impact of a disease such as cystic fibrosis on the healthcare system, society, patients, and the caregivers involved. One of the ways that you can measure burden of disease is utilizing a cost of illness study. These are studies that look at the social and/or economic burden of a disease by measuring direct costs, such as cost of medications, hospitalizations, indirect costs, such as those associated with time lost, and intangible costs, such as those that look at the impact of a disease on a patient's quality of life. Cost of illness studies are significant because they allow researchers to communicate the importance of a disease and thereby advocate for interventions that may mitigate disease burden. Now, in the context of CF, these interventions might include CFTR modulators or preventative measures, such as CF newborn screening. Cost of illness studies also allow in the allocation of research dollars, as well as serve as a basis for policy planning in the context of drug coverage, drug reimbursement, as well as the implementation of welfare programs. Now, as many of you know, with the recent introduction of CFTR modulators, several countries such as Canada had significant difficulty with regard to drug approval and drug reimbursement. And for this reason, in order to advocate for appropriate policy change, Cystic Fibrosis Canada was interested in developing an understanding of the current CF costing literature so that we can highlight the burden of CF in Canada. Therefore, we conducted a literature review with three main objectives. First, we wanted to identify all cystic fibrosis cost of illness studies in Canada and around the world. Given that there's many different ways to estimate the cost of an illness, we wanted to identify the methodology that's been used in the CF landscape. And lastly, we wanted to identify any current research gaps that exist in how the cost of CF was estimated. Therefore, we conducted a literature review using the following search terms. We used the term cystic fibrosis alongside other terms such as social burden, treatment burden, and healthcare costs. The three main data sources we used were Medline, Google Scholar, and Cochrane Review. Specifically, we looked at those studies that were published in the past 25 years and reported on the social and/or economic burden of CF, but also provided a detailed breakdown of how they estimated that cost. Cost effectiveness studies, as well as economic evaluation, among others, were excluded from this analysis. And so, what did we find? Well, using the search terms, we found a total of 601 studies. We then screened for duplicates, as well as for any irrelevant titles and abstracts, and then applied the inclusion/exclusion criteria. A final yield of 36 studies was included in this literature review. What we found was that only 4 studies were done in Canada over the past 25 years. Majority of studies were those in Europe, followed second by the United States. In terms of study size, majority of studies were less than 500 participants in size, with only a handful of studies over 2,000 participants, and these were those either in Europe or in the US. In terms of study perspective, or in other words, the type of costs that were included in order to estimate disease burden, we identified 3 across the literature. First, we had studies that used the healthcare system perspective. These were studies that looked at the costs incurred to the healthcare system, including costs of medications, hospitalizations, as well as CF clinic visits. Then, it was a societal perspective. These studies not only looked at healthcare costs, but also looked at the costs associated with time lost, such as lost time from work. And then there were studies that used the patient/caregiver perspective. These looked at the cost at the individual level to a patient and the caregiver, such as out-of-pocket expenditures. What we found was that majority of studies utilized the healthcare system perspective, and that only 10 out of the 36 studies used more than one perspective. In terms of study design, there were several unique variables or data sources that we identified across the literature. As you can see, studies used national registries, health administrative databases, surveys, and there were also a group of studies that were done at single centers, or in other words, at a single hospital site. Interestingly, what we found were those studies that were looking at cost of medications, hospitalizations, and clinic visits relied heavily on national registries and large health administrative databases, while studies that focused on individual level expenses or out-of-pocket expenditures relied on survey work. And those studies that were done at single centers or a single hospital had the benefit of having an access to their patient population and not only get healthcare costs, but also co-administer a survey and then capture those non-healthcare or indirect costs. Across the 36 studies, we identified 10 general costing domains. These have been categorized under 3 headings. So first we have our direct healthcare costs. These are variables, again, that refer to the cost incurred to the healthcare system. And so we had studies that looked at the cost of hospitalizations, CF clinic visits, prescription medications, and therapy devices. Now you might notice that medications and devices is also under non-healthcare costs. And the reason for that is because it really depended on which country the study was done in. In countries where the cost of a medication is incurred to the government, it would be a healthcare cost, versus in those countries where the cost of a medication is to the individual, it would fall under non-healthcare costs. Other out-of-pocket expenditures also included those associated with transportation and even household help. And then formal caregiving referred to the costs that were incurred with regard to hiring a private nurse or a personal support worker. Then we had those studies that looked at indirect costs. These are those associated with time lost. Studies looked at the cost associated with a family member taking care of a patient with cystic fibrosis. We had those costs associated with lost time from work, decreased productivity at work or presenteeism, as well as costs associated with early retirement, unemployment, premature mortality, and there were also a few studies that reported on the actual time spent on treatment for a patient with cystic fibrosis. What's important to note is that although these were the 10 costing domains that we identified, each study defined each of these variables much differently. And it really depended on the study design and perspective that they were utilizing. Now, in terms of the actual costs themselves, here I have a graph with the x-axis showing the study year, the size of the bubble representing the size of the study, so the sample size. And then on the y-axis, we have the maximum cost for cystic fibrosis per patient per year reported in the study adjusted to USD 2020. What we can see is that the greatest cost we found was around $280,000 USD. This was a cost in a study in the US, specifically at Boston Children's Hospital, that looked at the cost of cystic fibrosis and in those individuals that also had a diagnosis of depression. As you can see, it was quite a small study with only 40 patients. The second greatest cost we found was in a much more recent study that looked at the cost of cystic fibrosis and how it was impacted by the introduction of CFTR modulators. But the main key takeaway from this graph is that we weren't able to identify any specific trends or patterns in the costs that were reported. And the reason for that is because the methodology of how these costs were estimated differed greatly between the studies. Studies used different perspectives, different costing domains, as well as different data sources to actually estimate their costs. And so in summary, not only was there variability in the costs that were reported, there was heterogeneity in how these costs were estimated. Additionally, costing domains differed between countries. The example I gave was medications. In some countries, it would be considered a healthcare cost, while in other countries, it was considered a non-healthcare cost. And most frequently, we found that studies reported healthcare costs, or medications, hospitalizations, and clinic visits. And because it was the most frequently reported, it appeared to be the biggest contributors to cost. On the other hand, indirect costs, or lost time, appeared to be much less frequently reported. But in those studies that were done at a single hospital center that looked at healthcare costs, but also indirect costs, we found that indirect costs actually occupied a much larger proportion of the total cost of cystic fibrosis. As you would imagine, the cost of CF may also be impacted by certain clinical variables. What we found was that the cost of CF was greater in those with worsening disease severity or lower FEV1 percentage. Additionally, costs were greater with increasing age, greater in female gender, as well as with certain disease states, such as diagnosis of depression, pancreatic insufficiency, CF-related diabetes, and chronic bacterial infections, specifically a Pseudomonas infection. In much more recent studies, we found that modulator use tended to represent a much larger proportion of the total cost of cystic fibrosis. There were some gaps that we identified in the current literature as well. First, as I previously noted, majority of studies looked at the healthcare system perspective. And so these studies looked at those costs of medications, hospitalizations, and clinic visits. There was no standardization across the costing domains. Different countries defined the costing domains in much different ways, and this impacted the total cost that was reported in the literature. And then out-of-pocket costs were rarely included, especially in those studies that tried to capture healthcare costs. Indirect costs or societal costs were also rarely included. For example, psychosocial burden, quality of life, and the actual cost associated with treatment time was omitted and not included in the studies. And then in terms of the actual study sizes themselves, as I said, majority of studies were less than 500 participants. And in those that were greater, they relied heavily on large administrative databases linked to insurance companies. So, in summary, what we found was that there was a lack of cystic fibrosis costing literature, and specifically cost of illness studies in Canada, with only 4 studies being published in the past 25 years. Not only is there variability in the costs that have been reported, but this is because of the heterogeneity in how the cost of CF has been estimated. There is no standardization in the current literature about how to estimate the cost of CF. Studies have used different data sources, different perspectives, as well as different costing domains. And the majority of studies that we saw are utilizing a healthcare system perspective. They're looking at the cost of medications and hospitalizations, but failing to include costs at the individual level, such as out-of-pocket expenditures, or even costs associated with time lost from work or caregiving. And therefore, we conclude that there is an existing costing research gap in the current cystic fibrosis literature, and no single study has been able to capture the true cost and time burden of cystic fibrosis. So, what's next? Well, as I'd mentioned, Cystic Fibrosis Canada had originally gone into this literature review with the intent of highlighting the burden of CF in Canada. But clearly, from our review, we identified that there's a lack of research in Canada. And so, with that being said, Cystic Fibrosis Canada is currently underway in conducting our very own cost of illness study. We're looking at the social and economic burden of CF by focusing on healthcare costs, such as medications and hospitalizations, utilizing our CF National Registry, but also incorporating a survey and standardized questionnaires to capture costs at the individual level. This study is currently underway, and we look forward to sharing these results in the near future. With that being said, thank you all for listening to my presentation.
So one question we have is, based on your literature review, do you feel that it is possible to truly estimate the the true total burden or cost of CF?
Mm-hmm. Yep, that's a great question. So I think what the literature review really showed us was that, as I previously said, there's no single study that's been able to do it. And there's many factors that come into play. It really depends on the country where the study is being conducted, but also in terms of the access to the data. At Cystic Fibrosis Canada, one of the ways that we're going to be able to at least capture the close estimate or even true burden of CF is really relying on our national registry, which has healthcare utilization data for around 98 to 99% of patients that have CF in Canada. And then we also, based on the studies that we looked at, learned from lessons where using a survey or standardized questionnaire such as the CFQR is really going to help us capture those individual level costs. And then lastly, the benefit of being in Canada, we do have access to national costing information. And so putting that all together, we're going to be able to hopefully capture the true burden of CF.
Yes, question?
Yep. So the question was whether or not symptom burden was included, and what the current literature is with regarding that, and then also in terms of our own study. So what I can speak on in terms of symptom burden is that specifically when we talked about psychosocial burden, it refers to symptom burden, also refers to treatment burden, so the treatment time, and then trying to attribute a cost to that treatment, but also things like a comorbid diagnosis of depression, anxiety in those patients with CF. And the current literature that's out there, there were 1 or 2 studies that tried to really capture that psychosocial burden, but in doing so, they weren't able to capture the other elements of the true burden of CF. So for example, if they just focused on that indirect cost, they didn't look at costs associated with healthcare utilization or out-of-pocket expenditures. In the context of our study at CF Canada, the tools that we're going to be using, CFQR, as you mentioned, is one of those tools, but there's other tools like the Barthel Index that looks at cystic fibrosis and then assessing it from a disability perspective, but also looking at, for example, prescriptions associated with antidepressants, out-of-pocket expenditures related to seeing a psychologist or a psychotherapist.
Another question we had was, looking at your results, why do you think there are such big discrepancies in costs between countries?
Yeah, so so there's a lot of factors that come into play of why numbers might be different across the countries. I think like a simple answer would be, the researchers themselves, how they went on to the studies. There was no standardization. Costing domains were defined differently, different perspectives were used. But as I mentioned before, depending on the country, depending on the healthcare system of that country, costs are going to be different. They're going to be incurred in different ways. And then another thing that also differed not only between countries, but also within countries is access to data. Specifically, a lot of the single center studies that I talked about were done in urban centers where they had access to a lot of information with their patients. On the other hand, if you look at community sites, they're not going to have access to this information. And so their estimate of CF might be much different than an urban center.
Okay, any other questions? All right, thank you.
Okay, so our next presenter that we have today is Scott Sherwood. He is a senior specialist for policy and advocacy at the Cystic Fibrosis Foundation, and he is standing in for another team member who was ill today. So we're going to have him come and present his presentation on when insurance doesn't cover it, advocating to protect state CF programs.
Thank you. I will start by saying I am not Ashley Tharp, and will be stepping in her stead and try to do my best to give her presentation justice today. But talking about our work in collaboration with the community members, clinicians on our advocacy efforts on state level, providing additional assistance through state programs. No disclosures for myself or for Ashley. And jumping into a quick update on our background here, I'll go through our background on what we're going to cover today. We'll talk a little bit about state CF assistant programs. And we've got a few specific examples of those that we're going to touch on out of the states of Maine, New Jersey, and out of New York State that we'll touch on as examples of us working on these programs and restoring and protecting those programs. We'll talk about some of the strategies that we put in place to be able to protect those programs in those states and discuss the results in those places. So So with that, we will jump into something that we've talked about throughout this conference, is that, while we've made a lot of progress in what care looks like, and we've done that over the decades of deciding what CF care looks like through our CF model, through the treatments, through the available prescriptions and care that's available for people with CF. But unfortunately, that treatments and that care is expensive. We've seen nearly 3/4 of respondents in our health insurance survey indicated that they require financial assistance beyond traditional insurance. So that leads a gap. It leads assistance that's required. And that can be done through a number of ways, third-party assistance, manufacturer coupons. There's a lot of examples of that out there. Today, we're going to talk about what states provide. On this map, we've got a number of states that are indicated that actually provide additional assistance for people living with CF. So these are CF-specific programs in these states that offer assistance programs. And as I mentioned, we're starting to see increasing cuts to other forms of assistance, including third-party and pharmaceutical patient assistance programs. So that just elevates the importance for us protecting these state programs and why we need to ensure that people have access to their care through programs that are provided by our state-funded programs. And right here's an example from one of our passionate advocates out of New York, Melissa. And I think she kind of summarized what we're up against here. She says, "What aspect of my care will I do without because it's suddenly unaffordable?" And I think that's what's at stake when we don't take the time to demonstrate how important programs like this are, these state-funded programs. We need to be able to, on ourselves from patient perspective, from clinician perspectives, share with state legislators the importance of providing funding to these safety net programs. So jumping into some of the examples that we have, payers of last resort by reimbursing enrollees for services not covered by other forms of insurance. So some of the programs that we're talking about today, they cover things outside of what Medicaid would typically cover. So insurance premiums, DME equipment, supplements, cost sharing for hospitalizations, care visits. These are all things that we know that our patients require, what they need to make sure that they can continue to have those quarterly care visits, what they need to ensure that they can get to the clinician. And we know that these burdens outside of the care are the things that add up and create barriers that prevent them from continuing to receive the care that they need. So that's why we really want to ensure that these programs are in place so that our patients don't have those extra hindrances in place that prevent them from receiving their care. And jumping into some of the specific examples that we saw. So taking a look at the year in 2021, I'm going to share 3 examples from our advocacy team. And we evaluate policies across the country in a number of states, in a number of places. And these are 3 examples that we saw kind of take place and kind of set the stage in 2021. So first, starting with Maine's Children with Special Health Needs Assistance Program. What the state did in 2021 was adjusted the eligibility guidelines and made cuts to critical services. So changing those guidelines and the eligibility significantly dropped the people that would qualify for that program and be able to have assistance. In New Jersey, we saw this over the long term. So outside of, it wasn't a one-year cut, it was actually a smaller cut that in 2021. We saw a progressive cut over a course of about 3 years. We saw the program cut 35%, and that significantly reduced what that program could provide for people with CF in the state. And then in 2021, unfortunately, we saw the New York's Adult Cystic Fibrosis Assistance Program completely cut. So that was a very popular program. I'm sure most people in the state of New York that work in our clinics are familiar with that program and know what impact that made on our community and for our families that rely on it. So once we saw those programs changed and cuts, the foundation really had to gather our resources together, had to get together the community, different aspects of our resources and what we have to really start pressing the buttons and ensure that the legislature understands the impact of these programs. So first, we really started by collecting stories, understanding how the personal impact from patients and clinicians, that's what makes the difference. And so we really want to understand how people utilize those programs. We can look through the program descriptions and understand what's provided, how much assistance can be shared, but hearing those personal anecdotes and stories and experiences was one of the most effective things that we could provide. We then engaged with legislators, reaching out to their offices, working with people on leadership in those state legislatures. We had nearly 30 meetings across those 3 states, ranging in offices from Senate and House leadership in those states to with the Department of Health in those states. We also organized online grassroots campaigns. So we have a number of advocacy alerts in those programs in those states. We saw over 1,400 actions, emails sent out in those states, encouraging legislators to understand the legislation and encourage the restoration of those programs. We also worked in states like Maine to provide specific testimony, again, sharing to those offices and to those boards that overview allocation of them, personal impact of what that means. And then we also made additional requests to the Departments of Health to their FOIA to request data on the impact of previous years of those so we could build the case for their necessity and for their restoration. And so what we saw in Maine, the bill that the foundation did ultimately help draft and aim to restore the program was used to create a study that will be used in the Department of Maine. And on the graph here, you'll see our FOIA request results, really just demonstrating what we saw that was lost from that program. So in 2017 through 2019, we have a number of people with CF that are enrolled in that program and in total, and we see that number significantly drop. It drops from 258 total participants in the program to 3. And we saw for people enrolled with cystic fibrosis, the total from 186 to 0. So we pulled this data, we shared this, we built the case, and this has led to Maine opening up a discussion about returning that funding. In New Jersey, we actually, we worked with some really key relationships in the state there. So actually through partnerships of community members, we were able to have specific and targeted meetings with leadership in the House there in the Assembly of New Jersey and talk to them about the importance of this program. And, we really sold what it meant and what its community impact was. And we were actually able to restore an additional $200,000 to that program. So an increase of 83% coming back. And that was able to help the program administrators there in New Jersey provide additional resources, items like increasing the amount that can be used for food, additional deductible assistance, cost-sharing assistance. So that was really helpful for that community in New Jersey. And then in New York, we were able to make the case using that FOIA data, using the information, and more specifically using the experience of our volunteers in that state to make the case to restore that program. And we were able to get the funding back into the administration and now working to get that into statute. So we're halfway there, but definitely have a long ways to go as far as making sure that that funding gets into a bill, into the program, and is able to be administered to patients that need it most. And so what's next? This whole presentation is really an example of collaboration. These are just 3 examples of the work that the foundation does. This is one area, the protection of state programs and funding. We know that these are not the complete answer to cost and affordability, but we know that these programs help as a safety net and can be available for clinicians, for care centers, and for patients when they need it most. So when we find that, kind of easy places for us to weigh in, watch, and monitor, we want to make sure that now that we have these fundings in place in states, that we want to protect them, and we want to make sure that people with CF have access to them. As I mentioned, it's a collaboration. I've worked with care center members to be able to go into meetings and share their perspectives because that's what provides the anecdotes that we need. The patients are the ones that always drive the message home, and it's our continued advocacy together that makes the most impact. So with that, I will turn it over to questions and hopefully be able to answer some.
That was fantastic, Scott. And for those that know, he literally just did that fantastic presentation within minutes of getting here. So thank you so much.
Second time I saw the slides.
Yeah. Thanks. So thank you so much for filling in. That was fantastic. One of the questions that we have is, how does the CF Foundation become aware of cuts to state programs?
We have a whole team. So our team on the policy, specifically on the policy side, tracks and monitors legislation, not just state program, but other legislation that would impact people with CF. You know, we watch bills like copay caps. We watch a number of types of legislation, accumulator bans, to name a few. But we watch those through, governors propose their budgets. We watch closely with our stakeholders in each state. You know, it takes a lot of relationships that we have in those states that have these programs to be able to monitor them closely enough so that we can act quickly when we see cuts. And we also look to see when there's an opportunity for us to ask for improvements or increases in those fundings as well. We always want to be able to make the best case for those increases, always demonstrating the efficiency of the program.
Another question we have is, what role can care centers play in advocacy?
Yes, I mean, I got the right audience here for this answer. The clinicians are such an important part of advocacy because you're on the front lines. You see day to day the impact of these barriers that they have. We know that we've made so much progress in the fight against cystic fibrosis, and we still need a lot of work to be done. And we need to make sure that people have affordable access to those treatments to ensure that they can continue to live the full and productive lives that we want them to. So clinicians sharing your stories, providing the kind of numbers, the amount of people that utilize the program, but more specifically, sharing your personal stories of what you go through each time to help ensure a patient can get their treatment. Because we've made this progress, we don't want to lose it. We want people to be productive members of society and to be participating and to be able to live the lives that we know that they can.
All right. Don't be shy. Feel free to zip in some questions to us.
Texas program has a several-year, at least a year, so we may have a program. We do have a program.
With children with special health care needs, yes, that's.
Texas, which is a big state, but anyway, you can't count on it immediately. You can't just apply it, put your name on a waiting list like you would for a business.
Well,
When they're born.
yeah, it is. Yeah, that's a great question in the front here about children with special health care needs in Texas. And there's been a history of there being a very long waiting list for that, where people have to wait several years on that waiting list. But we've actually worked really closely with the program and administrators there, and we've seen them be able to clear the majority of those roles, not getting through everyone, but being able to clear those roles over the last 6 months or so. There's still a lot of work to be. And this is all very, very recent. And over the last couple of years previously, it's been a real challenge there for sure.
And so what types of data are most persuasive to state legislatures?
Data, usage, the amount of people that utilize the program in your states, just depending on the specific program. It's really painting the picture of why this funding is necessary. They see a number that's on a line item and they say, if I'm asked to trim budgets, if I just take 5% off this budget, what is that? It's not much. But for us, it's to say, that 5%, that's $50 and for an individual patient, or it's $100. It's not much for an individual patient, but when they're trying to travel 3 hours to their closest care center, an hour, and we want to be able to pay for overnight stays, or we want to put them in positions to be able to get their health care, that small amount makes a huge impact on their overall health.
Any other questions? Yes.
Yeah, so the question is, we've got a number of states that have specific safety net programs in place. What efforts are being done in the other states to ensure similar programs that could be utilized? We are looking for opportunities, to look for situations that could grow into future programs. Some of those programs in other states started out of different histories, different contexts, have kind of branched out from other programs. But for new programs to start, we're really looking to shore up some programs like Medicaid. Want to make sure that people are able to utilize that. We want to work on other cost availability issues, like making sure that copay assistance is provided. We want to make sure that copay caps are in place. But ultimately, we are looking for opportunities to make sure that people have affordable access to the care, even if we have to come up with creative solutions in those states. But we're always looking for opportunities for that legislation to come forward. And once they do and we track and we watch it, that's when we can advocate for it.
All right, excellent. Thank you so much.
Thank you.
Okay, so that brings us up to our final presenter. So next we have Mary Alice Gaho. She is a pharmacist over at Children's Hospital of Los Angeles, and she'll be speaking on the topic of, is there a disparity in access for elexacaftor, tezacaftor, ivacaftor in Hispanic versus non-Hispanic patients with cystic fibrosis?
Thank you for that introduction. I wanted to start off by sharing that I attended my first NACFC in 2018 in Denver. And I remember sitting in the back of the room and sitting in a healthcare disparities session, and it really impacted me. And so being able to present today on a topic on health disparities and medication access really feels like it's coming full circle. And so thank you to the chairs for selecting me today. So let's go ahead and get started. The following relationship exists related to this presentation. I did have grant support from the CF Foundation. So let's go back over 1 year ago on June 9th, 2021. This was an incredibly eventful day, especially if you worked at a pediatric CF center, because on this day, the US Food and Drug Administration they announced that they approved the use of elexacaftor, tezacaftor, ivacaftor, which moving forward, I'll say Alex-Tez-Iva, for children ages 6 through 11 years old who have at least one copy of the F508del mutation or certain mutations in the CFTR gene that are responsive based on lab data. And so with this announcement, this meant that 1,500 people with CF became newly eligible to receive Alex-Tez-Iva. And with this expanded eligibility, we saw this as an opportunity to assess the impact of equity in our CF Care Center for this medication. But first, let's look at what we already know about access and eligibility in CF minority groups. Studies by McGarry and colleagues have established that minority groups that identify as Black, Indigenous, or people of color, or BIPOC individuals with CF have significantly lower pulmonary function than non-Hispanic Caucasians. In addition, BIPOC individuals have more rare mutations, making them less likely to qualify for CF modulators. And then lastly, we do also know that this ineligibility and/or access among ethnic minority groups contributes to a worsening healthcare disparity for treatment. So the objectives of today's talk will be, number one, to determine if Hispanics with CF receive Alex-Tez-Iva as much as non-Hispanics, and how this affects their clinical outcomes at our CF center. And number two, to bring awareness to health disparities and inequities that still exist by sharing the unique experience of our CF center at a local level. This was our study design where we conducted a retrospective chart review between October 1st, 2019 to January 31st, 2022, and we included anyone who had a diagnosis of CF. The data we collected was ethnic background, genetic mutation, lung function in terms of percent predicted forced expiratory volume in 1 second, or FEV1, nutrition in terms of BMI Z-score, and insurance type. We performed a chi-square test to compare eligibility and Hispanic origin, and an unpaired t-test to compare lung function and nutrition, with a statistical significance if the p-value is less than 0.05. This is a breakdown of our CHLA demographics in terms of ethnicity. So on the left, you'll see that a majority of our patients identify as white, which is 83%. And it's important to note that this white ethnicity includes both non-Hispanic whites and Hispanic whites. And also wanted to mention that this data was collected from the CF registry. And then on the right side, we further broke it down, and we found that up to 60% of our patients identified as Hispanic white and 40% identified as non-Hispanic white. So you can really appreciate that there is a large amount of Hispanics at CHLA. And this is just a brief overview of our patient demographics. We had 145 patients total in our time frame, with, again, 40% as non-Hispanic, 60% as Hispanic, and about half of males and females, with 48% males and 52% females, and a median age of 14 years old for non-Hispanic white and 12 years old for Hispanics. And then we looked at a breakdown of their insurance type. So moving forward, all the graphs that I'll be presenting, the orientation will be the Hispanics on the left and then non-Hispanics on the right. So you'll see that Hispanics have a majority of their health coverage is through state insurance, which is 77%, and 23% commercial insurance. Whereas the opposite is true in non-Hispanics, where they have a majority coverage with commercial insurance at 61% and 39% for state insurance. And in California, state insurance is through Medi-Cal, which is our form of Medicaid, and also California Children's Services, also known as CCS. This type of insurance program treats children under the age of 21 years old with certain health conditions, including CF, and those who meet the certain CCS program criteria. And I wanted to highlight that CCS does also provide coverage for CFTR modulators. So let's move on and look at our eligibility results. So for those who were eligible based on age and mutation in the timeframe of our study, we saw that 62% of Hispanics were eligible and 76% of non-Hispanics were eligible, with a p-value of 0.08. But there was no difference in eligibility at our center between the two groups. And then when we looked at eligible patients who are actually receiving the medication, we found that 83% of eligible Hispanic patients received it versus 98% of eligible non-Hispanics, with a p-value of 0.019, meaning that eligible Hispanic patients are less likely than non-Hispanic patients to receive Alex/Tezaiva at our center. Next, moving on to the clinical outcomes in terms of lung function. So we first did an overall comparison, and we looked at the percent predicted FEV1. The overall mean percent predicted FEV1 for Hispanics, you'll see, was similar compared to non-Hispanics, with a p-value of 0.32. And then we further categorized to look at lung function based on receiving Alex/Tezaiva. So in purple, you'll see the Hispanics and non-Hispanics receiving Alex/Tezaiva, and then in yellow, you'll see not receiving Alex/Tezaiva. And you'll see that on the left, that Hispanics receiving Alex/Tezaiva have a higher percent predicted FEV1 than Hispanics who are not receiving Alex/Tezaiva, with a p-value of 0.009. But this was not the case in the non-Hispanic group. And next, looking at BMI Z-scores. So again, we looked at an overall comparison, and we found that Hispanic patients overall had a significantly higher mean BMI Z-score compared to non-Hispanics, and this is consistent with what we do already know in the literature as well. And then similarly, we did another breakdown of whether or not you were receiving versus not receiving the medication. And when we further analyzed it, we found that the BMI Z-scores were again higher in the Hispanic group, but access to and receiving Alex/Tezaiva does not appear to play a role. And then, of course, we did also have some limitations to our study. For example, we did not control for age, gender, comorbidities, disease severity, socioeconomic factors, and given that it was a retrospective study, we did have a limited time capture of our data. So we took data points of percent predicted FEV1 before starting and after starting, rather than a change in before and after, and similar with the BMI-Z scores. And then lastly, we also did not account for if the patients were on prior CFTR modulator therapies switching to Alextezaiva. So given our findings, especially of what we saw on lung function, it was important to follow up with the reasons of, what are the reasons Hispanics, despite being eligible for the medication, are not able to receive it as much as the eligible non-Hispanic patients. So there was a total of 9 patients who were in this eligible Hispanic group that were not receiving Alextezaiva. So starting at the top in this group, you'll see 3 patients were not on the medication due to parental preference to decline. Next, 2 patients were pending transition to the adult center, where in this particular case for these 2 patients, it was very challenging because based on their adherence and their transition process, it made more sense for them to initiate this new medication with their adult team and have them do the initiation and the monitoring. We also had 2 patients who had delays in eye exams, and for these 2 patients, it is a representation of how much we are also struggling to get our eye exam clearance for cataracts prior to starting. We had struggles in the past with patients getting approved by insurance without having the results of this cataract clearance. And despite our efforts for prompt referrals, parents have cited their own challenges in finding optometrists or ophthalmologists who are willing to accept their state insurance, or now that ivacaftor is even as low as 4 months old, the eye doctors who are willing to perform eye exams that young. And then we also had another patient who experienced a delay in insurance authorization despite having Medi-Cal and CCS. And so this patient, it's worth looking into what are some variable factors in the state insurance, in the approval process, where some people may be approved faster than others. And then lastly, we had 1 patient who experienced an adverse drug reaction where she experienced a total body rash. Despite stopping and re-challenging slowly and dose adjusting, we decided for her case it was best for her to resume back on ivacaftor alone, which she is now safely on. And though there's a variety of reasons listed here, we will next focus more on taking a closer look at the reasons of why families are choosing to decline due to their personal preference. So when we further discussed in our clinic visits with the parents and patients who decided to decline, these are some of the reasons they've specified. So one parent in particular had concerns for safety in terms of potential side effects. The mother had quoted for her daughter who was about to enter puberty, she was concerned that she would have difficulty discerning any mood changes attributed to puberty versus mental health changes attributed to, these were her exact words, attributed to mental health side effects from Alextezaiva. And these are, things that are unique to pediatric centers, which was definitely a valid concern. And we do know also, on a more serious note, that mental health side effects is a growing area of concern related to Alextezaiva. So that was her personal choice for her daughter, and her daughter echoed the same feelings as well. And then also another cited reason is the parents' perception of their child's current state of health. So we looked at what was the lung function of these 3 patients, of these parents who have decided no for them. Their percent predicted FEV1 ranged from 96% to 125%, which is pretty high. So the parents in this case did not perceive any added benefit when considering adding the risk of a medication that could potentially cause, liver toxicity, cataracts. It's a hard sell when you're seeing your child do so well already. And, even from a clinician standpoint, you can't guarantee that, that's not going to happen. And then a third reason was their personal belief regarding children in research and hesitancy in starting new therapies. So this leads us to look more into what is currently known about trust in research in both pediatrics and in minority groups since this expanded eligibility of Alex-Tez-Iva has come out. So let's take a look more at trust in medical research and how far we've come through the years. So it's well established that parents' knowledge, their attitudes, and their perceptions towards research does influence whether or not their child will participate in clinical trials. For example, in 2009, Raja Kumar and colleagues described that the degree of parental distrust is significantly greater in African American parents versus white parents. In addition, their level of education, being less than high school education, was also associated with significantly greater distrust. And then in 2014, a systematic review conducted by George and colleagues, they reviewed and assessed to perceived barriers and facilitators for health research participation among ethnic minority groups. What they found was that across 4 ethnic minority groups, which included African Americans, Latinx, Asian Americans, and Pacific Islanders, they found that one of the most common themes as a barrier was having lack of access to information, particularly quoting that there was not enough, there was a language barrier which prohibited them from receiving the information they felt like they needed. And then 10 years later from where we started, from what these other studies have shown, race and perceptions continue to be top predictors of parental trust in medical research, with parents' race positively associated with Caucasians having higher levels of trust in medical research versus African Americans, as well as a higher education level being associated with more trust in medical research. And so although these 3 studies that I presented, they're not specific to cystic fibrosis, I would like to highlight the fact that within the decade of this timeline, there were 3 CFTR modulators. The last one was just missed right before Alex-Tez-Iva had been approved and announced. So 3 CFTR modulators have come to be approved, yet these perceptions have continued to persist in the background through the decade. So therefore, the takeaway message from sharing this timeline is that we must strongly consider attitudes towards trust in medical research when we assess why are patients or parents declining or choosing not to be on Alex-Tez-Iva. But now let's take a look at a more recent survey that was conducted by Kramer, Golenkoff, and colleagues, where they sought to understand the health and perspectives of people with CF not benefiting from CFTR modulators. And what stands out here is that the respondent demographic included a relatively diverse group with a total of 437 respondents and 72.5% of people who were BIPOC individuals ineligible for modulators. 43.4% were parents of people with cystic fibrosis. And then they also included a small percentage, 3.7%, of people who were minors under the age of 18 years. And I wanted to point out that this study was conducted from June 10th to July 1st, 2021. And if you recall from the beginning of the presentation, June 9th, 2021 was the day that the FDA had announced their extended approval for eligibility. So this survey was conducted at a very opportune time. And in their survey results, they asked their respondents, what is your willingness to participate in future clinical research trials? And they found that 76.7% were yes or affirmative responses, that they would express interest in participating in future clinical research trials, citing that the top 2 reasons were, 1, they liked the possibility of benefiting one's own health, and 2, the possibility of making progress towards finding a cure for everyone. So given these results that included a pretty diverse representation of respondents, it leads one to question if, 1, over time, could we progressively see evolving attitudes and perception on medical research for underrepresented groups, whether it be pediatric, minority, rare mutations? And then also, how will this play a role in influencing eligible patients to be open to available therapeutics such as Alex-Tez-Iva? So just to formally conclude all that we reviewed today, the results of our study showed the following. There is no difference in eligibility for Alex-Tez-Iva between Hispanics and non-Hispanic patients with CF at our center. Fewer Hispanic patients received Alex-Tez-Iva than non-Hispanic patients, and Hispanic patients receiving Alexa/Zyva had a higher percent predicted FEV1 than Hispanics not receiving it. And we speculate that parental perceptions of research in minority groups continues to be an ongoing contributor to healthcare disparities, despite recent advancements in CF therapies. Efforts to understand these perceptions is a critical factor to guide parents to making well-informed decisions in their child's care. And we should assess improvements in healthcare disparities and changes in parental perception of clinical research in CF as we get more available data of long-term safety, since this does seem to be a big factor. And I would like to acknowledge and thank my brilliant and amazing CF team at CHLA for supporting me through this incredibly important topic. Without them, I wouldn't be standing here today.
One question we have is, what changes have you made in your daily practice to address the results of the study?
So one thing I have tried, knowing that we've struggled so much to find providers, optometrists and ophthalmologists who are able to see our patients, and knowing that's kind of a more tangible, effort that I could help with. If we've had other patients come to us who have similar insurance, similar zip code, and so, if I find families who are in a similar situation, I will, use that information and ask, what eye doctor did you use? What is their information? And share that with families who are also struggling.
Yes.
I can't find the actual name of it, but there is I think I put it on the list of them, that
The mobile eye exam. I'm hoping they come in December to LA. I've tried connecting. Did you have success with it too?
Yeah, so we had to do chunks at a time.
Right.
Areas that
Okay. Yeah. I have, yeah. Oh, yes. So she was asking if our center has utilized I think it's Vertex-sponsored, a mobile eye exam clinic. And so I believe the next time they'll be in Los Angeles is in December. So I do have a couple of patients in mind that we would like to refer that service to. But I think one of the challenges has been when I've connected with them, I think there is only like twice a year that they are in our location. And so that's been hard too. But I'm hopeful that I can utilize that service. So I'm glad you brought that up. Thank you.
You still have the hand in the back? Yeah.
Oh, yeah. Oh, sure.
Dr. Socrates?
I would like to bring up the notion about health literacy and numeracy. So I have a family that they're concerned about side effects, in part was because they were afraid that we were going to, damage the liver for life, she was going to be blind. And they really, beyond the Spanish language, it was really a matter of, people assume that people understand fractions of percents or things like that. And so helping them better understand how rare these risks are and things. But I think we still have a long way to go to really recognize people's limits in health literacy.
So she was just sharing that we still have a lot of progress to be made regarding health literacy because even though there are, booklets and pamphlets that get translated, it's still at a reading or literacy level where, it's presented in percentages or incidences. And so that's not amenable to, our family's learning style, especially if they're of a different language.
And then I know you touched on the concept of mistrust and entering into clinical trials. And There's been data to show that there's a disproportionate underrepresentation of Hispanic children in cystic fibrosis trials that is likely contributing somewhat to the health disparity that's existing, one of many factors. So do you have any thoughts on how to overcome this mistrust?
So at our center, we're very fortunate because we have two core CF research team members who are actually of Hispanic origin. And so I think that has helped a lot, seeing how much they're able to, empathize with the patient and better explain. I think making sure that being able to understand and giving them the time. I think giving them the time to understand, what the study is, being able to take home the materials and not pressuring people, because I think that's also another thing. Like, CF research teams are very busy, and so, enrollments can be a very hectic time. But I think letting the families actually digest the information and ask more questions, I think that actually makes a big difference.
Excellent. All right. Thank you so much.
Thank you.